Hey, what's up, everyone? Welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're taking a deep dive into a topic that might seem a bit hairy. But trust me, it's absolutely fascinating. Have you ever wondered why our scalp, with its 100,000 hair follicles, 100,000 sebaceous glands, and all those erector pili muscles, can be the source of so many pesky problems? Well, today, we're breaking down the science behind scalp skin diseases, straight from the chapter by Maria K. Hordinsky on skin diseases of the scalp. So grab your coffee, sit back, and let's get into it. Let's kick things off with the basics. Our scalp is a powerhouse of activity. It's packed with a high density of sweat glands and pilosebaceous units. Imagine there are roughly 100,000 hair follicles on your scalp. And with every follicle, there's a sebaceous gland and an erector pili muscle working together. Now, hair isn't just for style. It actually protects our scalp from UV light. But if you're balding or have thinning hair, you're more prone to sunburns, photo damage, and even photosensitivity. And here's a kicker. Having all that hair can sometimes make it tough to clean your scalp thoroughly, which can set the stage for conditions like dandruff and seborrheic dermatitis due to the colonization of Malassezia yeasts. Crazy, right? So, what kinds of scalp issues are we talking about? Broadly speaking, scalp diseases fall into three main categories: inflammatory dermatoses, infections, and neoplastic conditions. But wait, there's more. Lesions on the scalp can also be tied to photo damage or even systemic diseases like dermatomyositis. And don't forget those bullous conditions like pemphigus vulgaris and pemphigus erythematosus. Basically, if there's something going on with your scalp, it might fall under one of these umbrellas. Now, how do we diagnose these scalp issues? Most of the time, it's all about the patient's history and a good, thorough physical exam. But sometimes, we need to dig a little deeper. For instance, if we suspect tinea capitis, which is a fungal infection of the scalp, we might do a potassium hydroxide, or KOH exam, and even send samples off for fungal cultures. If there's a suspicion of a bacterial or viral infection, then we can get cultures to pinpoint the culprit. And in cases where allergic contact dermatitis is on the table, patch testing comes into play. For those tricky bullous disorders, a biopsy for direct immunofluorescence can be our best bet. The key here is a tailored approach. No two scalp conditions are exactly alike. All right, let's break it down further with a quick run-through of the different scalp conditions, along with some epidemiology and clinical pointers. Trust me, it's a lot, but stick with me. Allergic contact dermatitis. Who's affected? It's pretty common and tends to hit females more than males, can occur at any age. What's the deal? It's pruritic, meaning it's super itchy, and it usually kicks in within hours or days after contact with an allergen. You typically see erythema, that's redness, edema, and itching on the forehead, eyelids, and ears, though it rarely shows up on the scalp itself. Atopic dermatitis, population. Common overall, but you see more scalp involvement in infants, with a slight male predominance. Symptoms. It's also pruritic and can really make life uncomfortable for the little ones. Cicatricial alopecias, prevalence. Relatively uncommon, making up about 3.2% to 7.3% of all alopecia cases. What to look for? Think of conditions like discoid lupus erythematosus, lichen planopilaris, and central centrifugal alopecia. Patients might experience acute or chronic hair loss with symptoms like itching, burning, pain, redness, and sometimes drainage. On exam, you might notice a visible loss of follicular ostia, inflammation, redness, scaling, pustules, and even bogginess of the scalp. Psoriasis, demographics, common, more often seen in males, and it can affect any age group. Clinical signs, ranges from asymptomatic to itchy red papules and plaques with that classic silvery thick adherent scale. Seborrheic dermatitis. Key points, super common, especially in a bimodal age distribution, peaking in infancy and again in adulthood, with males slightly more affected. In infants, you might recognize it as cradle cap, with pink to yellow patches and white greasy scales. In adults, it often shows up as dandruff, white flakes, typically without redness. But in moderate to severe cases, you can see red plaques with those greasy scales. Next up, let's talk about the infectious and infestation causes on the scalp. These can be real troublemakers. Dissecting cellulitis, epidemiology, uncommon, mostly hits males between 18 and 40 years. Symptoms: look for drainage, itching, and pain. It's often part of a follicular triad that includes acne conglobata and hidradenitis suppurativa. Clinically, you might see recurrent pustules, scarring alopecia, and those boggy plaques with sinus tracts. Staph aureus is frequently the bug we find here. Folliculitis. Who's at risk? It can affect anyone, depending on factors like occlusion, heat, humidity, immunosuppression, medications, or even conditions like diabetes. Presentation typically presents with follicular pustules, about 1 to 3 millimeters, and sometimes inflammatory papules, often accompanied by itching. Head lice. Demographics, common in kids, especially girls aged 3 to 11 with long hair, though black children are less commonly affected. How do they spread? Through direct contact or fomites. Think combs, brushes, hats, helmets, and even headphones. Often, the occipital scalp, posterior ears, and neck get hit hard. In some cases, you might also see pyoderma and regional lymphadenopathy. Herpes zoster. Who gets it? Commonly seen in older individuals with no gender bias. Clinical picture. It kicks off with a painful prodrome and then erupts into vesicles on a red base in a neat dermatomal pattern. Tinea capitis, age group, most common in kids aged 3 to 7, and it's relatively rare after puberty. How it shows: it can be asymptomatic or come with adherent scales. You might see areas of alopecia with broken hair fibers that look like black dots, kind of a dandruff-like scale too. Carry-on, frequency, uncommon, but when it happens, children are more affected than adults. Features: very tender, characterized by inflammation and suppurative lesions on the scalp. You could also see sinus formation and, rarely, mycetoma-like grains. Sometimes animals can be the source of the infection. Now, let's step into the realm of systemic and bullous diseases, where the scalp conditions are a sign of something more widespread or severe. Dermatomyositis, epidemiology. It's rare and tends to affect females more. Clinical signs: intensely itchy, with diffuse, scaly red patches on the scalp and post-auricular, that's behind the ears, erythema. Bullous diseases: pemphigus vulgaris, who, uncommon, equal in males and females, typically appearing between ages 50 and 60. Symptoms: patients report painful lesions, and you might see flaccid blisters, crusting, erosions, and tufted hair fibers. Pemphigus foliaceus, who, also uncommon, affecting both genders equally, usually after age 50 to 60. It's more common in areas like central and southwestern Brazil and Colombia. Presentation: there's often a burning sensation or pain with crusting, scaling, erosions, and redness. Bullous pemphigoid. Epidemiology: uncommon as well, with onset typically after age 50 and affecting both genders equally. What to expect? It's pruritic with red patches and blisters. And finally, let's talk about neoplastic conditions of the scalp, basically skin cancers and related lesions. Actinic keratosis. Epidemiology. This one's pretty common, more often in males over 50, especially those with fair skin and a history of sun exposure and balding. Presentation: these lesions can be tender, persist for months or even years, and when there are many, patients might even mistake them for a rash. They typically appear as skin-colored, yellow-brown, or pink gritty papules and plaques with an adherent hyperkeratotic scale. Cutaneous T-cell lymphoma. Occurrence: uncommon, with a male predominance. How it shows: it can be itchy and present as eczematous or psoriasiform patches, plaques, or nodules. Now, I want to be upfront with you. This article by Maria Hordinsky is a fantastic primer on the diagnosis and evaluation of scalp dermatoses, but it doesn't dive into specific treatment protocols. So, if you're looking for medication names and dosages, like for instance, using oral terbinafine for tinea capitis or topical corticosteroids for psoriasis, you'll have to consult additional resources or clinical guidelines. The focus here is on understanding the spectrum of scalp diseases, their epidemiology, clinical presentation, and how we evaluate them. Isn't it wild how much complexity is hidden in something as seemingly simple as our scalp? From the sheer number of hair follicles protecting us from UV rays, to the myriad of diseases, from inflammatory conditions like allergic contact dermatitis and atopic dermatitis, to infections like head lice and tinea capitis, all the way to systemic and even neoplastic issues like actinic keratosis. Our scalp really is a microcosm of dermatological challenges. And understanding these details is crucial, not just for us as curious minds, but for doctors who need to nail the diagnosis based on history, physical exam, and targeted tests like KOH preps, cultures, patch tests, and biopsies when needed. So what's the takeaway? Whether you're a patient, a fellow clinician, or just a curious soul, staying informed about these intricate details can make a real difference in early detection and proper management. If you enjoyed this deep dive into the world of scalp diseases and you learned something new today, hit that like button, subscribe, and join the conversation in the comments below. I'd love to hear your thoughts and any questions you have. Let's build this community of informed, engaged minds together. Next week, we're switching gears and diving into another groundbreaking topic that might just change the way you think about everyday health. Trust me, you won't want to miss it. This is Dr. Rod from ShockDoc Medical, signing off. Stay curious, stay informed, and keep questioning the world around you. Until next time, take care, everyone.